Please join me in welcoming Dr. Barada and Dr. Deiling.
Thank you. So I'm Britt Deiling, again, from the University of Virginia, and we're going to have a little bit of a pro-con debate between general anesthesia and regional and neuroaxial anesthesia for hip surgery. So I have no financial disclosures. And just our goals and objectives. So I'm going to be reviewing the pros and cons of general anesthesia for hip surgery, again, focusing mainly on ambulatory total joint arthroplasty and hip fractures. Identifying some patient-specific outcomes that may be affected by the type of anesthesia, and discussing some concerns of geriatric patients undergoing hip surgery. So to cover the broad range of hip surgeries, I'm going to separately review the evidence both for hip fractures first and then for ambulatory total joints. So just some background. So osteoporotic hip fractures are associated with a pretty significant morbidity and estimated 1-year mortality of 21% in the US. There's roughly about 300,000 admissions for hip fractures per year in this country, and it's actually anticipated that the incidence will triple by 2050. So as part as multidisciplinary efforts to improve patient outcomes, there's been a lot of considerable research directed towards identifying the optimal anesthetic and analgesia techniques for these patients going under hip fracture surgery over the last decade. It's been hypothesized that regional anesthesia may improve outcomes by avoiding the risks of general, providing some opioid-sparing analgesia in these pretty complex patients. But for neuroaxial anesthesia, evidence of clinical benefit has been somewhat inconsistent in the literature, and we'll review that. So one thing I kind of want to draw your attention to is the recommendations from our orthopedic surgery colleagues at the AAOS, and they have pretty significant evidence that supports the concept that hip fractures really should be fixed within 48 hours of admission because they're associated with some better outcomes in regards to mortality, pain, certain complications, and length of stay. And it's been found that patients delayed due to medical reasons actually ended up with the highest mortality. So it may be this subset of patients that actually could potentially benefit most from having surgery earlier rather than later. So the timing can determine the anesthetic plans just based solely on patient-specific factors, whether they're on anticoagulation, what their volume status is, things like that. So just kind of keep this timing in mind when we're pre-op planning for these hip fracture patients that need optimization. So for example, it might not be beneficial to wait 72 hours if someone is on, home anticoagulation to follow the guidelines to proceed with a spinal, but maybe doing general instead to get them within that 48-hour window. And now I want to talk about some hip fracture backgrounds, talking about two of the bigger trials that came out in the last decade. So the first one is the REGAIN trial. So it's spinal anesthesia or general anesthesia for hip surgery in older adults. So this was a 2021 randomized superiority trial that evaluated spinal anesthesia as compared to general in previously ambulatory patients 50 years of age or older who were undergoing surgery for hip fractures at 46 institutions within the US and Canada. And this trial showed a similar risk of delirium, time from randomization to discharge, inability to walk independently of 60 days, and 60-day mortality in these patients who either received spinal or general. And additionally, secondary analysis revealed that spinal anesthesia was associated with more pain in the first 24 hours and actually higher prescription analgesia use at 60 days. There is definitely some limitations to this study, including the study population, which may not make these results generalizable to the sickest, most complex patients, which Dr. Barada will discuss further in our session. And then the RAGA trial, which was the effect of regional versus general and the incidence of post-op delirium in hip fracture patients. This was in 2022, so right around the same time, another randomized clinical trial that looked at 950 older adults, and they either got regional anesthesia with no sedation at all or general anesthesia. And it showed that it did not significantly reduce the incidence and the severity of post-op delirium in older patients undergoing hip fracture repair, whether they got the spinal with nothing or general anesthesia. So we all know that, so not all patients are created equal. And we know that patients that present for hip fracture repair can be very different. For example, my very active 70-year-old father-in-law had hip fracture repair this year, but he fell during a 70-mile mountain biking ride. So he's definitely not your typical patient. And then probably more commonly, the other frail elderly patients with complex medical issues on anticoagulation that had a hip fracture from a ground level fall. So I want to talk about a little bit about frailty in the geriatric patients, and then specifically when you're looking at frail patients undergoing hip fractures. So this was from the ASA 2025 practice advisory for the perioperative care of older patients. So this information is generalizable, not specifically to hip fractures, but frailty, as we know, it's associated with a 2 to 5 fold increase, greater risk of complications, mortality, not being able to be discharged home, and development of new disability. And pre-op frailty is actually one of the strongest predictors of post-op delirium. In 25 to 40% of surgical patients, even pre-op, live with meaningful degree of frailty. So we really need to, be able to preoperatively identify these patients to allow optimization. And then when you look through that ASA practice advisory guidelines, it basically says that intraoperatively, the management of older patients entails its own set of considerations, and the role of anesthesia technique remains debated. So they said, we recommend choosing either neuroaxial or general for older adults when either is clinically appropriate, and that the evidence suggests no superiority with either technique in reducing post-op delirium. Now, looking specifically at frailty in hip fracture patients, these are two studies that came out recently. One is that frailty when using the Frail scale, which is a 5-item questionnaire looking at fatigue, resistance, aerobic, exercise, illness, and loss of weight. And it independently was associated with a 1-year mortality in patients undergoing hip fracture surgery, where the mortality was about 21% in patients considered frail by this scale versus 4% in non-frail patients. And then another study that basically showed that frailty in these hip fracture patients was significantly increased all-cause mortality both at 30 and 90 days after hip fracture repair. And then one thing I just want to kind of draw our attention to that a lot of our orthopedic colleagues use is this orthopedic hip frailty scale, or score, I'm sorry, which looks at age over 85, congestive heart failure, history of malignancy, if they're institutionalized or not, and their functional status. And they found with this validation study that the OFS is a significant predictor of short-term post-op mortality that outperforms or performs on par with other frailty scores. And they found that with a score of 2 or more, they had increased risk of mortality, many complications, failure to rescue, which is basically worsening of their condition despite having the repair, and a prolonged and more costly hospital stay. So definitely something to keep in mind when these patients come to us. Obviously with hip fractures, it's not like we have a lot of time beforehand to optimize them, but definitely something to keep in mind when you're doing your anesthetic planning and thinking about these patients post-operatively. So I want to switch gears just for a little bit and talk about pain after hip fracture surgery. And this study was a randomized clinical trial that came out in about 2022 and found that general anesthesia was also associated with slightly less pain in the first 24 hours post-op after hip fracture repair. And again, was associated with lower prescription analgesic use at 60 days. But in all honesty, these differences are small and overall not associated with any improved long-term outcomes. So I don't want to get too far off topic, but as a regional anesthesiologist, I did want to make a plug for the evidence supporting nerve blocks in hip fracture patients. And in contrast to the evidence for general versus neuroaxial, the literature on peripheral nerve blocks has yielded way more reproducible benefits in hip fracture patients. So this was a 2020 Cochrane review that looks at 43 randomized control trials, and that shows some pretty high certainty evidence that these nerve blocks both reduce pain on movement and risk of delirium, but also some moderate evidence for the risk of chest infection and time to mobilization. But we need some larger studies to be able to clarify any effects on mortality or MIs. So general anesthesia, it is an acceptable option for these hip fracture patients. So again, the Regan and Raga trials that were published looking at delirium, ambulation, and mortality, and they really didn't find that it didn't confer mortality benefit nor a reduction in delirium or a greater amount of people that could ambulate at 2 months. But again, the trials weren't perfect. There's a limited percentage of elderly patients and excluded probably the most frail patients at baseline before surgery. But it does kind of call into question, should we be telling patients that spinal anesthesia is a safer choice for hip fracture surgery? So again, as always, a risk-benefit discussion should take place with each patient, and ultimately, the patient should be informed of the state of evidence and help guide this decision. Now we're going to switch gears for the second part of my talk and focus specifically on general anesthesia for ambulatory joint arthroplasty. So this was a study, I want to go over some background first. And this is a study in 2023 that basically shows the predictions from 2020 to 2060 in outpatient both hip and knees. So there's an exponential increase. So more of these patients are definitely coming down our pipeline. We'll be doing a lot more of these cases, and a lot of them are shifting to the outpatient setting. And then I want to make note, when you're looking at the literature for outpatient total joints, the wording isn't always consistent in what outpatient means. So when I think of outpatient joint arthroplasty, I think of like same-day calendar discharge. But there's a study that came out in the joint arthroplasty a couple years ago that actually showed that when looking at the literature, only 12% of total hips and 11% of total knees that were labeled outpatient were actually same-day calendar discharge. So outpatient in some studies can mean same day, 1 night, or 2 nights. But for the most part, it's considered 24 hours or less. So what are the risk factors for ambulatory joint arthroplasty? So the data is not consistent, but the things that we believe are not appropriate for outpatient joint arthroplasty are, and this is not, hard guidelines by any means, age over 80 or a high frailty index. When you're talking about patients who are above A3, definitely 4. The BMI cutoff is definitely variable. I'll say I work at an ambulatory joint arthroplasty center, and we do not have a BMI cutoff of 35. It's much higher than that. But when people have poor nutritional status, significant bleeding disorders, or severe end organ disease, they're probably not appropriate for the outpatient setting. And the table on the right is another good example, and this is from a 2022 paper from Dr. Arnon looking at the safety considerations of outpatient arthroplasty. So when you're thinking about the prediction of success of which patients are going to do well getting their joint fixed in the outpatient setting, there are some studies that is looking at the OARA, which is the Outpatient Arthroplasty Risk Assessment, and it's basically 9 comorbidity criteria that I have listed here with a weighted score. And the tool has a high positive predictive value of like 81% for same day or next day discharge. And this table shows that looking at the OARA tool, which is the blue line compared to the ASA scores, that the OARA actually has better correlation with predicting same day discharge than ASA scores. So what are some of the reasons that people fail same-day discharge? So this is a systematic review looking at the top 3 reasons that people were not able to go home the same day after a total joint on the outpatient setting. So nausea, hypotension, pain, we need to specifically keep these in mind regardless of anesthetic choice in order to facilitate that same-day discharge home. Other reasons were also failed physical therapy and urinary retention, which obviously definitely can be affected, and I'll talk about in a little bit based off our anesthetic plan. So again, as a regional anesthesiologist, I want to make the point for the strong evidence in the use of peripheral nerve blocks, not only in hip fracture patients, but sorry, this slide just went out and just came back. But also for the benefits in the total joint arthroplasty patients in the outpatient setting. And this actually was not for the analgesic benefits, but for the lower odds complications of cognitive dysfunction, respiratory cardiac events, surgical site infection, clots, and blood transfusion. So when you look at the evidence for general versus spinal for ambulatory total joints, there's actually very little data that's specifically looking at ambulatory joints as opposed to inpatient joints. But this is a study in 2024 from the Journal of Arthroplasty, specifically looking at ambulatory joints. And they found that both spinal and general led to reliable same-day discharge and overall had similar 90-day complications. But they did find that they were having higher pain scores with general anesthesia. And not surprisingly, length of stay was, the general versus spinal was determined on what they were using in the spinal. So the MEPI spinals had a shorter length of stay than general, and the general had shorter length of stay than bupivacaine, which I don't think anyone is surprised by. And then this was a RAPM study in 2022. It looked at over 11,000 patients. It was a multi-centered retrospective cohort study between 2017 and 19, and their endpoint looked at 30-day post-op complications, mortality, MI, DVTs, PE, stroke, and acute renal failure. And then when they were looking at spinal versus general, they thought that spinal was going to show some improved outcomes, but it was unclear whether these were present in the outpatient setting, given that these patients are a lot healthier than a lot of the studies that look at inpatients. But they found that the anesthesia type was not associated with an increased risk of complications, and that spinal improved outcomes that predict readiness for discharge. And this is that same study, so no difference in complications. The spinal did have some benefits in pain, opioid use and PONV, but they did have a longer PACU stay, about a little less than an hour. And they felt that they were a little bit slightly more able to be discharged home same day with the spinal versus general, like 33 versus 23%. And then, so post-op urinary retention. So we know that spinal is generally associated with a higher incidence of POR than general in these total joint ambulatory patients. And the reported ranges of the incidence of POR is anywhere from 17 to 40%. And it really depends on, if you're going to use a long-acting local anesthetic and if you're going to include any intrathecal opioids. But the risk of POR with spinal definitely increases male sex, older age, like over the age of 65. Again, if you're going to put intrathecal morphine, if you're going to give them a lot of fluid, and if they have a higher pre-op bladder volume, which would suggest that they have a history of BPH. So this is definitely not something to brush over, and something that, in our center we really look into, because if they can't pee, then they can't go home, and then urology has to get involved, and that kind of defeats the purpose of them having a joint where they can go home the same day. So, we definitely have had patients where, we've chose general over spinal for this reason alone, especially if they have a history of post-op urinary retention after a spinal. And then this is one other study that I want to talk about, and this study kind of looked at what were the factors that determined the choice, so like why people got a spinal versus general in ambulatory setting. And it found that the main factors influencing the choice of whether they got a short-acting spinal or general was, one being the patient's choice. If the patient had fear of an alternative technique, what their stress and anxiety was, their expected ease of recovery, and the efficacy of the technique. But it is interesting that when looking at this, both arms, spinal versus general, the patient's both global satisfaction was over 90% in both study arms. So either way, they were satisfied with both their anesthesia and surgical care. And then obviously, to touch on patients who can't have a spinal, right? So if they have a contraindication, whether it's coagulopathy, infection at the surgical site, or bacteremia, granted, these patients, if they have this, they would not be done in the outpatient setting. If they had like a true allergy to local anesthetic, any preload dependent cardiac lesions, increased ICP, they can't cooperate. Or if this, based off of prior back surgery, hard way, or if it's just unsuccessful or not feasible, or if they refuse. So just something to keep in mind, when making our choice of plan. So in summary, for both hip fracture and ambulatory joint arthroplasty, general anesthesia, it is an acceptable option. So some things just to take away that, a lot of these hip fracture surgeries should ideally be fixed within 48 hours of admission for better outcomes. For hip fractures, based off the Regain and Raga trials, that spinals have not been shown to be superior, but again, may not be true for the sickest, most complex patients. When looking at total hips, general is also reliable for same-day discharge, similar complication rates. So, overall, we have to make patients aware of the options, do what's right for your specific patient, yourself, your institution and surgeon, and then, as always, do your peripheral nerve blocks for these patients. Thank you.